This week, we're just going to kind of talk about anatomy of the cerebral vasculature. Um, some of this should be a little bit of a refresher because we have touched base on it, and I think Vascular 1 when we started studying branches of the carotid, vertebral, circle of Willis. So it's going to kind of come around now full circle, and we're going to start taking a deep dive into these vessels that we image for cerebrovascular ultrasounds. In addition to this, I'm just going to do a little bit of the next PowerPoint that covers some of the stroke symptoms to just kind of introduce some of those terms and get you into thinking about risk factors of why we perform these exams. Then just kind of general introduction. We're going to talk about the cerebral arterial system, the blood supply for the central nervous system, the extracranial, carotid, and vertebral arteries. So that's important, extracranial versus intracranial. So again, those are two separate exams. Extracranial are those vessels that exist outside of the skull, outside of the cranium, which are the ones we image with ultrasound. And then the intracranial arteries primarily referring to the circle of Willis, which again can be imaged and examined with the transcranial Doppler. Understanding the cerebral hemodynamics, what do the waveforms look like? What do we expect a normal, CCA, ICA, ECA to look like? And then talk about some collateralization. So in terms of the extracranial vessels, basically comprised of four vessels. We have our common carotid artery, or common carotid arteries, one on each side, right and left. The common carotid artery then bifurcates or splits into our internal and external carotid arteries. And then we have the vertebral arteries that are branches. So our first branch is off the subclavian arteries on each side. Intracranial, it's the circle of Willis. So some general information. The brain, only accounts for about 2% of our body mass or body weight. But receives about 15 to 20% of all of our cardiac output. So 15 to 20% of all our blood winds up, when it's ejected from the heart, winds up going to the brain. And consumes about 20% of our oxygen supply. All right, so our branching patterns. So we have our aortic arch. So again, we have to be able to familiarize ourselves with our branches coming off the aortic arch. So our first branch off the aortic arch is our innominate or brachiocephalic artery. That then splits and branches into our right common carotid and right subclavian artery. On the left side, the left common carotid artery is a direct branch. It's that second branch directly off the aortic arch. So in that case, when we're imaging the carotid arteries on the right side, it's pretty easy for us to see the origin of the right common carotid artery. It's very, very hard to see, with us in vascular to image the origin of the left common carotid artery. Those of you in CVS, when you're doing your suprasternal notch picture and you see that candy cane with the aortic arch, you guys are the ones that can kind of, get a peek at the origin of the left common carotid. But generally in vascular, we come down as far as we can and we don't typically see the origin. The common carotid arteries then split into internal and external carotid arteries. So both right and left will branch into your internal and external. Again, I just want to bring home the point. Don't think internal and external as in the way that they're splitting and branching and the way you see it on diagrams like this, because you'll get it wrong every single time. If you label this, internal and external, you have to look and see where they're going. Don't go based off of, just labeling, internal's inside, external's outside, when in actuality, we're going to see in a moment, the internal carotid artery is more posterior and lateral, and external is more medial and like towards the face. So again, you have to look at the branch pattern, where it goes, and if there are any branches that we see extracranial to kind of make that identification. The third major branch off the arch is our left subclavian artery. And then both of our subclavians, the first branch coming off the subclavian arteries on either side are going to be our vertebral arteries, our right and left vertebral arteries. It's just my little kind of breakdown or schematic of the branching patterns. If you want to look at it, visualized in another way. So we've seen this picture before. We've labeled this one before. Again, your right innominate, brachiocephalic, common carotids on either side. Common carotids run up and then bifurcate into your internal and external carotid arteries. So again, this is a prime example of, orientation of the vessels. Internal carotid artery is actually more lateral compared to the external carotid arteries. Again, pictures, diagrams, you have to look at things, and even sonographically, that branch that we see coming off the external carotid artery likely represents ophthalmic. I'm not ophthalmic. Superior thyroid artery. You can use that to help identify, which is internal, which is external. We know that internal carotid arteries are the ones that bring blood flow to the brain, so they continue upwards, enter into the skull, and eventually supplying the circle of Willis and the anterior portion of our circulatory pathway within our brain. Vertebral arteries coming off each subclavian, then continue up, and then converge. They enter into the foramen magnum through the opening in the back of our skull, come together to form the basilar artery and form the posterior circulatory pathway within the circle of Willis. There's again another diagram. Don't be tricked, by the way the vessels are oriented on your picture. Kind of look at what's going on. Common carotid splitting into internal and external. External will always have branches on it. And then the ICA will continue upwards and enter into the skull and go towards the brain, towards the circle of Willis. Again, that's another way you can identify, internal, external. Look for those branches, look to see which one, is going towards the brain or entering into the skull and supplying the pathways of the brain. So common carotid artery, or CCA. So it's posterior and lateral to the thyroid gland. Patient's thyroid glands are kind of in the middle of the neck here. And when we put our probe down, we can oftentimes see the thyroid gland with the carotid artery, but it exists posterior and lateral. So if the patient's neck is turned, it's posterior to the gland and lateral. So meaning kind of more towards the back of the neck. It's deeper to the jugular vein. So again, when we're imaging, when we're doing our upper venous, we saw the jugular vein and the carotid artery below it. So it's posterior or deeper to the jugular vein, as well as the sternocleidomastoid muscle. So there's a specific muscle that's there in the neck that you can oftentimes visualize, and it's deeper to that. With common carotid artery, there are no arterial branches. So as we scan up the common carotid arteries, they shouldn't start throwing off little branches. If you do scan a carotid artery that's got branches coming off of it, save those pictures because you'd be famous. That would be in a journal article. You can write that up. I've never ever seen that, but I've heard that it is a possibility in literature. As you scan up the common carotid artery, it should be nice and uniform in diameter. You shouldn't see any areas of intense dilatation, so it shouldn't be aneurysmal. We get a slight bulging of it once we enter an area of that vessel known as the bulb. So that's right before it bifurcates, it splits into your internal and external carotid arteries. The right common carotid artery is, like we said, is a branch of the innominate artery or brachiocephalic. Left common carotid artery comes directly off the aortic arch, so it's the second major branch off the aortic arch. So that carotid bulb or carotid sinus, like I said, is expanded portion of the common carotid artery just before the bifurcation or split into your internal and external. So that carotid bulb or that carotid sinus is an important landmark or feature of this vessel because it's a common site for plaque development and intimal thickening. So this is where the majority of our atherosclerotic plaques are going to start to form, and we wind up with that narrowing is in the bulb and bifurcations. So any test questions you get on boards and from me, you know, where's the most common location for atherosclerotic plaque in the, you know, the carotid system or the extracranial carotid vascular system? It's going to be in the bulbs and in the bifurcations. That's where we see our plaques. So when we get into lab and start scanning this, we're going to make sure we get nice pictures for the bulbs and bifurcations. Those are kind of like your money shots, like when you're doing carotid scans. That's where the doctors really want to see, you know, nice 2D, nice color, good Doppler waveforms through that area of the vessel. Again, you know, if you have to label vessels, look for your branching to signify external carotid artery, because external carotid artery is going to have branches coming off of it that we can visualize. As well as the location of it. External carotid arteries more medial and towards the face and supply the muscles of the face, the glands, the tissues of the face, whereas the internal carotid artery continues up, enters into the skull, and terminates in the circle of Willis. A nice common carotid artery, again, should be nice, uniform in diameter as we're coming up, especially, you know, in the proximate and distal segments before we get to that bulb. Ideally, you know, you're nice and perpendicular over the vessel when you could see the echogenic intimal lining on either side. So we can see a nice echogenic intimal lining here. We can see, you know, fairly decent over there. So we know we're nice and perpendicular over the vessel. That's what we're going to be trying to shoot for. Again, optimize your image, decrease your depth, get nice and close, you know, so you can visualize the vessel clearly. Oops. And then as we're scanning up towards that bifurcation, you're going to notice the vessel starts to bulge a little bit, and we enter into that area of the bulb, which is just before the bifurcation, the split into internal and external. So in sagittal, you know, it's can't really tell which is internal or external, you know, unless we see a branch coming off one of those vessels, and we can then ID it as you know, external carotid artery. Don't go by the orientation because people's splits are different, you know. Kind of, and you know, this is a carotid artery coming up my neck. Some people's could split. Some people's are oriented that way, where it's splitting off that way. Some might be a little more that way, some that way. So not everyone's going to have this nice picture of a tuning fork. It all depends how it splits. And we could see it in transverse as we're coming up, you know, as we're scanning up. That's our jugular vein, you know, carotid artery is going to be deeper. So common carotid artery should be a nice round circle, jugular vein, posterior to the jugular vein or deeper to the jugular vein. As we start coming up, it starts to get a little bit larger and bulge. That's going to be our bulb. And then once we get into bifurcation, people's carotid arteries can bifurcate like that, where it's side by side. Some people's carotid arteries will bifurcate like this, one on top of each other. You know, they could be a little bit off axis or something like that. So everyone's going to be a little bit different. You know, so they could be kind of side by side, one on top of each other. They could be right next to each other. Patients who bifurcate when they're side by side like that, you're never going to get a nice tuning fork image unless you change your whole approach and get it to split one on top of the other. patients who bifurcate, one on top of each other, that's when we start seeing, when we turn it sagittal, you get that nice tuning fork picture. So I just kind of want to kind of bring that point home. So when you're in the lab scanning each other and you're trying to get this picture, it might never happen based off of how they split and how they bifurcate. So that's one thing. So those of you that, have that kind of off axis, bifurcation or side by side or off to the side, we're going to work on getting the common carotid artery bulb into your ICA, then common carotid artery bulb into your ECA as two individual pictures. So that bifurcation we said and bulbed, again, this area is our prime area where those atherosclerotic plaques are going to be building up. So again, we want nice, clear 2D images, nice color images showing, filling wall to wall. Some techs will even utilize power Doppler in this area just to make sure, that, it isn't just low velocity flow and it truly is plaque that's developed, in those areas. So you might see some techs put power Doppler on when they get to that area to obtain those images. Right, so internal carotid artery now. So these are, I'm just going to kind of speak generally because it's not 100% true necessarily for everyone. In general, the ICA, the internal carotid artery, is larger than the external carotid artery, and it's more lateral. So it's, if you kind of think of the patient's head turned to the side, it's going to be more lateral or more posterolateral, so more towards the back of the neck compared to the ECA. So this is comparing to the ECA. It's larger and more lateral. Supplies most of the anterior circulatory pathway for the cerebrum, the eyes, the forehead, and the nose. Oriented posteriorly towards the mastoid process, so meaning more towards the jaw or the back of the jaw. So it's more posterior, more lateral, more posterior, more lateral. Again, big important one, it has no extracranial branches. So there are no branches for the ICA that we see outside of the skull. The first branch of the ICA is intracranial and the circle of Willis, and that's our ophthalmic artery. So that's the first major branch there, is intracranial and the ophthalmic artery, which supplies blood flow to the eyes, to the orbits. Part of the circle of Willis is this carotid siphon where the ICA makes kind of like that S turn. So that's when we get to circle of Willis, we'll look at the carotid siphon. So it continues to the base of the brain, where it then branches into eventually the anterior cerebral, middle cerebral, and we also have the posterior communicating artery there. So kind of like that trifurcation in the circle of Willis. So it terminates and ends where it branches into those three major vessels. So here we can see ICA and PCA. As it's coursing, up the patient's neck, enters into the skull, into the brain, and then our first branch is that ophthalmic artery there. Don't worry about all the various, C1, C2, C3 segments. So you guys can scratch that. All right. ECA. So typically, or generally speaking, it's the smaller of the two between ECA, ICA. Supplies blood flow to the neck, the scalp, the face, some of the glands, and it has multiple branches outside of the skull. So the first branch off the ECA that we can sometimes see is this superior thyroid artery. So it's way down here branching off and then bringing blood flow to the thyroid gland. Additional branches include the ascending pharyngeal artery, lingual artery. We have the occipital artery, which runs posterior, going towards the back of the brain, or back of the skull, sorry. So occiput is back here, occipital artery, facial artery, also sometimes referred to as the external maxillary artery, posterior auricular artery, which comes behind the ear, maxillary artery, and then superficial temporal artery, which is kind of along the temple here. So if you ever feel like, if your pulse on your temple there, that's the artery that you're feeling, is that superficial temporal artery. The reason those two are highlighted is because those are the two that you can really utilize to try and identify external carotid artery. So superior thyroid artery is one that we could typically visualize and see near the bifurcation, and we see that little branch. So we're like, all right, I see the little branch of the superior thyroid artery. Yep, that's definitely ECA. Superficial temporal artery, we can perform a maneuver that's called a temporal tap. So while you're pulse wave Dopplering the external carotid artery, you can actually do these tapping maneuver on the patient's temporal artery, and those taps will actually get translated back down the vessel, and we can pick up those oscillations when we're Dopplering. So we'll see it during the diastolic portion of that waveform while we're tapping those little ripples on the waveform. And we can, again, use that to identify external carotid artery. Because we'll see in a moment, sometimes pathologies can cause the ECA to look like the ICA with the waveform. Or the ICA could be very high resistance and look like the ECA, or very similar. And it's hard to distinguish the two just based off a Doppler waveform. This was showing, and don't have to go crazy, memorizing all these guys, but just these major branches of the ECA do have further smaller branches that extend out. And we're going to see in a moment, these smaller branches of the ECA have anastomoses and connections with the ICA. So again, ECA and ICA, though they are independent, there are anastomoses and collateral pathways between ECA and ICA. In the event, we do have atherosclerotic plaque blockage, in the ICA, the body's going to do whatever it can, again, to get blood flow to the brain, because that's the most vital organ in our body. And some of those collateral pathways are then going to open up, and we'll have retrograde flow, and that's when, Circle of Willis is doing its thing to supply blood flow to those territories that are, being starved for blood. We even have connections between those ECA branches and the vertebral arteries as well. If we ever have any issues in the posterior circulatory pathways, that occipital artery that runs back towards the occiput or back of our skull has branches or connections with the vertebral arteries. These are just some more diagrams showing all the branches of the external carotid artery. Okay, just kind of differences between external and internal carotid arteries. So in a normal healthy patient, where there's no disease present, really the best way to determine, which is to analyze the Doppler characteristics, do a pulse wave Doppler, listen to the waveforms, what does the tracing look like, because they are very distinct from each other. There are certain characteristics, that are, pertain to external versus internal carotid artery. So the main thing is that resistive index, looking at how much diastolic flow there is compared to that peak systolic velocity with external versus internal. So internal should be very low resistance. We should have a lot of diastolic flow because the brain needs that continuous supply of blood, versus the external carotid artery, which is much higher resistance. Aside from that, you could use your general orientation of it. ICA is typically larger than the two. ICA is more posterolateral, so more towards the back of the jaw, more posterior, whereas ECA is more directed towards the nose or the face. So I say ECA face or nose, ICA more back towards the ear or the jaw. And then that temporal tap maneuver. On the ECA, we have well perceived oscillations that we see, and then the ICA, we poorly perceived oscillations, so we can use that temporal tap. We can also kind of get a good idea with our color flow as well. So when we're imaging, the bifurcation ECA and ICA, and we have our color on, if one of them, goes black or even turns blue for a momentary period, it's pretty safe to assume that that's the external carotid artery, whereas the ICA will continuously have blood flow, so it should always have color within it. It should always stay red. If we had a patient's ICA that was turning black like that, they would be blacking out every time it went black. It's basically a sleeper hold. Like the ICA has to have that continuous blood flow. They would be in a world of trouble. If it was pause, we have momentary disruptions of that flow. Our ICA Doppler waveform. So it's a nice, pretty ICA waveform. So here we have common carotid artery going into the bulb and then bifurcating into that ICA. The ICA Doppler waveform and nice fast upstroke, and then a gradual diastolic runoff. And it's very low resistance. Our baseline's all the way down here. Everything is well above that baseline. If you're to measure that end diastolic velocity, you're significantly above that baseline, representing a good amount of diastolic flow. And then you compare those two velocities, you should have a very low resistive index, so something between like 0.5, 0.6, 0.7 at the high range, but should, be in that 0.5 to 0.6 range. Versus external carotid artery. So ECA, again, you have that fast systolic rise, but because it's much higher resistance now, the velocity drops really quickly. So, after peak systolic, you have a very sharp deceleration of the blood flow. So ECA, I say it's very pointy, very spiky. It almost looks like a needle. If you could kind of look like, if I was to poke it with my hand and it looked like it would hurt, it's probably the ECA. Another characteristic of the ECA is it has a deep dicrotic notch. So this area here, this dicrotic notch represents the separation between systole and diastole during the cardiac cycle. Some patients, that dicrotic notch can even dip below the baseline. So you can see it drop all the way down below the baseline. So there might be a momentary period where it becomes triphasic and turns blue for a brief second. So if you see a deep dicrotic notch, a very sharp, systolic peak waveform, and then much less diastolic flow. So you can see how much closer that is to that zero baseline, representing much less flow during end diastole. And then if you're to put those numbers into your resistive index equation, peak systolic minus that end diastolic divided by that peak, we'll have an RI that's much closer to 1. So yes, this is still technically monophasic, but the resistive index compared to that carotid or the internal is much higher. So this was at the bifurcation. We can visualize the branch coming off that vessel. So again, that's one way. Again, we can identify external carotid artery by the visualization of those branch vessels. So that's likely the superior thyroid artery, that first branch off the ECA. All right, so vertebral and basilar arteries. So the vertebral arteries on each side, right and left, are the first branch off their corresponding subclavian arteries. They supply the posterior part of the brain, so the posterior circulatory pathways and vascular beds, so things like the medulla, the cerebellum. That's important because there are certain symptoms that patients might present with that, indicate to us where the disease or the blockages could potentially be. So namely the cerebellum, when we start talking about the stroke symptoms, things that affect balance and coordination, we're thinking posterior circulatory pathways. Um, Branches of the vertebral artery supply the medulla and the interior surface of the cerebellum. The vertebral arteries enter the foramen magnum of the transverse process of the. I'm sorry. So they enter into the brain of the foramen magnum, but the vertebral arteries extracranial, when we're in the neck, they enter into a part of the spine, and that's how this vessel gets the name. It enters into the vertebral column. So there's a small little foramen or small little hole in one of the transverse processes that sticks out. So there's a little bony prominence that kind of sticks out of each vertebrae, and there's a little hole in that, and the vessel actually passes in that hole as it's coming up the neck, up the cervical vertebrae of the neck. Enters the base of the skull at the foramen through the foramen magnum, and then they come together to form that basilar artery intracranial. These vertebral arteries are a collateral route when we have obstruction or occlusion in the innominate or subclavian arteries. So we're going to talk in depth about a condition called subclavian stele. And so this was the vessel as it enters into that small foramen of the transverse process of the spine. So here's each vertebrae of the spine, and it's passing through the bone through that little foramen or opening in the vertebrae. So when we image vertebral artery, it has a very distinct, image that we're going to try and get that allows the radiologist or the doctor or the surgeon, who's reading your exam to know that this is the vertebral artery. So ideally, when you get your picture, you want to kind of image in this area as it's passing through the vertebral columns. It's easier for the doctors to know, like, all right, yes, this is the vertebral artery. Yes, you can, image that smaller segment, more proximal where it's not in that vertebral column, but you just better be darn sure that you're imaging the vertebral and not another vessel. So this was showing that segment that exists outside of the vertebral column, the cervical spine, where it connects to the subclavian artery. But again, our typical picture that we're going to try and go for is imaging the vertebral artery in between, each vertebrae. So each vertebrae, since it's bone, is going to create this shadowing. So we get this dropout and this shadowing, and we don't pick up any of that vessel as it's coursing through. So here we can see the artery here, and then our two vertebrae with the shadowing. So we're going to Doppler kind of right in between. Get a nice color picture Doppler. Look at the direction of the flow. Is it antegrade or retrograde? Is it going towards the brain or away? And then assess our Doppler waveform. So vertebral artery waveform should be very similar to our ICA. So think of these as kind of like little baby ICAs. They're much smaller in diameter than the internal carotid artery, but it's going to the brain. So it's got the same, final destination. So it's going to have very similar Doppler characteristics. It should nice quick rise, systolic rise. So there's no targus parvis, and then a gradual runoff. And then again, a lot of diastolic flow. So this is, again, pretty high or above the baseline. Just the velocities are less, they're lower because they're smaller in caliber. There's less blood flowing through these vessels. So the velocities are just going to be naturally less. The basilar artery is formed at the base of the pons by the coming together of the right and left vertebral arteries. So they join together to form the basilar artery. Jeopardy fact, basilar artery is the only artery in the body that's formed by the coming together of two arteries. So there's no other artery in the body that does that. Everything in arteries branch and bifurcate, and they're whatever the bifurcations are those new arteries. But this one's formed together by the coming together of two arteries. Courses upward, yeah. If you're ever on Jeopardy, final Jeopardy question. Thanks, Alex. Courses upwards, it could be in a barn, bar trivia. Courses upwards and divides into our posterior cerebral artery. So the vertebral arteries come together, form the basilar artery for a segment, and then it splits into our posterior cerebral arteries for our circle of Lewis. Supplies the entire pons. So basically think of like the brain stem, the medulla oblongata, the cerebrum. I'm sorry, the cerebellum. Um, so again, forms the part of the circle Willis that bifurcates into those posterior cerebral arteries. And now intracranial or circle Willis. So we know this as the hexagonal arrangement of arteries. Circle Willis is made up of the anterior cerebral arteries, the middle cerebral arteries, and the posterior cerebral arteries. So again, those are our three main players. Your anterior cerebral, middle cerebral, and posterior cerebral. And then we have communicating arteries, an anterior communicating artery, and then two posterior communicating arteries. There's one single anterior that connects the anterior cerebral artery, so it connects the right and left, hemispheres of the brain. And then the two posterior communicating arteries connect that posterior circulatory pathway, so it connects the posterior cerebral artery with basically the origin of the middle cerebral, or where the ICA, terminates and ends. So the posterior communicating arteries combine the posterior circulatory pathway on one side to the anterior circulatory pathway on the same side. So anterior communicating artery communicates right and left hemispheres. The posterior communicating arteries communicate anterior and posterior circulatory portions of the brain. Yet these are very important because they serve as collateral pathways or channels when patients have significant hemodynamic lesions or significant stenoses and blockages in their extracranial circulatory pathways. So just showing both vertebral and the ICAs kind of overlaid as they enter into the skull and then form the circle of Willis. There's our old president. So when we get into learning transcranial Doppler, we're going to go into this, deeper with our whole transcranial Doppler lecture, learning about flow direction. Or for right now, I kind of want you to kind of just visualize, understand that, again, most of our blockages are going to be extracranial. We said most of the atherosclerotic plaques are in the bulb and bifurcation, so down in the neck. So that's going to limit or, severely reduce or even eliminate blood flow in this internal carotid artery. So there's no blood flow getting past that blockage. There's no blood flow filling this vessel anymore. The body still needs to get blood flow to the territories of the brain that are being fed by the ICA on that side. So that's where the circle of Willis now comes into play. It's going to steal, or not steal. Well, yes, it does steal, but it's going to rely on the other side that may not have, the disease to get blood flow into those territories. So, if this is absent of blood flow, we're going to get increase in flow on the contralateral ICA. So there's going to be increased flow on this side. It's going to fill those vessels, going to fill the anterior cerebral artery. But now blood flow is going to cross over that communicating artery and go in retrograde to the opposite direction through that anterior cerebral and feed, the middle cerebral pathways. It's going to cross over and then go up and feed the anterior pathways. So it's going to perfuse, all that portion of our brain from the other side. So that's when us as sonographers, we know that there's disease on that side. We've done our exam. When we go to do our intracranial studies, we recognize that we have a collateral pathway. And what we have to start learning what we're going to expect to see. If this is blocked, we expect, and we see this reversed, we're going to look or expect to see that this is reversed now. Blood flow coming across, and then this is reversed to feed all those pathways. We can also get some help from the same side. So we'll have increased flow in our vertebral arteries, elevated velocities, increased flow, and we'll get flow up that posterior communicating now, filling those vessels to then supply the middle cerebral and anterior cerebral arteries. So it's all working in conjunction to, again, supply blood flow all to those territories of the brain. Circle us. These are a little complicated to follow. They're anatomical variants. So a lot of the anatomical variants that we see, most common anomalies involve absence or underdevelopment of one or both of the communicating arteries, which decreases the collateral potential. So when we have, anomalies or anatomical variants, yeah, so there we go. So a lot of anatomical variants are issues with the circle of Willis and issues with those communicating vessels. So they're either underdeveloped or they're not developed. And then you can imagine those patients that don't have, sufficiently developed or underdeveloped communicating vessels. When there's issues on one side, they're the ones that have those catastrophic strokes, and that wind up with permanent neurologic damage. They don't actually recover from those strokes, because those brain tissues, unfortunately are starved for blood as a result of the stroke. It's the patients, that have good development of these pathways. They're the ones that, tend to have less, true cerebrovascular accidents. They might have the mini strokes, Rhines. So in addition to our cerebrovascular anatomical variants, so in addition to them occurring with the circle of Willis, the other most common anatomical variants involve the aortic arch. So if you ever get boards questions that talk about, like where are the most common anatomical variants seen in the cerebrovascular system, it's issues with the aortic circle of Willis, the communicating vessels, or it's anatomical variants in the aortic arch. So A represents our anatomic arch. Some patients might have what's referred to as a bovine arch, where they have, instead of 3 branch vessels, they only have 2 coming off. Or they share a common with the spot. So if you choose with that left common primary artery. They finished, man. They've been working on this side of the building for forever. I know. Where's something? So bovine arch refers to that left common carotid artery coming off of the brachiocephalic or innominate. So that left common carotid artery doesn't have its own origin off the arch. So it either comes off the brachiocephalic here, or it kind of shares a common stalk or common base. So that's a bovine arch. So most common, about 20%, but you're going to see that left common carotid artery has a branch off the brachiocephalic there. And then our left common carotid artery a little further up there. So I'm sorry, right common carotid artery a little further up. The other major anatomical variant that you might see, aside from having the bovine arch where you just have the 2 branches, is dealing with the vertebral arteries arising off the aortic arch. So you might have a vertebral artery that arises off the aortic arch, particularly on the left side. So that left vertebral artery coming as like kind of a 4th branch. So I've seen questions about bovine arch. They might ask about that. Just understanding that the left common carotid artery is a branch off the brachiocephalic. That's basically the definition of a full vine arch. So having the left CCA a direct branch off, instead of directly branching off the arch, it's a branch off the brachiocephalic or not. So the reason it's called that is because that's what we see in cows. So that's how it gets its name. This is what we would see if we were to dissect the cow. So the brain, some of the hemodynamics depends on that constant blood supply. Because there's little circulatory reserve due to the brain's high metabolic rate. There's no significant oxygen or glucose storage in the brain. It depends entirely on vascular maintenance. So even short episodes of cerebral flow interruption can bring about cerebral dysfunction symptoms or even cellular death. So adequate perfusion to the brain, meaning enough blood supply to the brain, it depends on certain factors. So there are outside factors that will determine, the amount of blood flow that's able to get to the brain. So one of the outside factors is our systemic blood pressure. So we need to have enough blood pressure to keep blood flow going to the brain. So if your blood pressure is very, very low, what happens when your blood pressure is low? You faint. So anyone who has orthostatic hypotension, when you get up too fast, you start feeling dizzy. That's because of that sudden change in blood pressure. When you sat up suddenly, it makes you dizzy. So we need to have good systemic blood pressure. The blood pressure has to be sufficient enough to push that blood flow and keep it going to the brain. We need to have a strong cardiac output. So the heart needs to be strong in order to pump that blood flow to the brain. So patients who have had heart attacks, their heart is weak, they're elderly, they're going to have less perfusion going to the brain because they have poor cardiac output. And then blood volume. If you're bleeding out, you have a GI bleed, you're hemorrhaging somewhere, your blood volume is very low. You're going to feel woozy, you're going to feel lightheaded because blood flow is not getting to your brain. Bless you. You'll learn when you go to the ICU and you have patients who've had stroke and they want blood flow getting to the brain because they've had a stroke, an ischemic stroke. They'll raise their blood pressures intentionally. So you might go into their ICU, you see their blood pressure on the monitor, like, oh, that's really high. But that's intentional. They want that. They're trying to get blood flow to the brain because of that stroke. So they falsely elevate their blood pressure. There's intrinsic factors, so that will also control, the amount, or I want to say control, but dictate the amount of blood flow that gets to the brain. So things that's intracranial pressure. So if a patient's had an accident, a traumatic brain injury, they were in a motor vehicle accident, and now they have a subdural hematoma, they're bleeding in their brain, that's putting pressure on the vasculature of the brain as there's swelling going on. That increased pressure is going to decrease flow. So they got to do things like a craniotomy where they remove a portion of the skull to relieve some of that pressure. There's also arterial oxygen tension, carbon dioxide levels within the blood. This leads to vasoconstriction and vasodilation. So with the raised carbon dioxide levels, blood vessels will dilate, will increase perfusion. The thickness of the blood, are they very dehydrated? Is the blood very viscous? As well as the tone of the vessels. But really the two main things that control or regulate the amount of blood flow within the brain is our O2 and O2 concentration levels. So they play the greatest role in regulating and modulating the cerebrovascular resistance. So kind of just general rule of thumb, when CO2 levels rise in our body, that CO2 is a vasodilator, so vessels are going to dilate, and that's going to increase perfusion. So, you could do certain therapies to increase their O2 levels to cause vasodilation to try and get more blood flow into the brain. So the body's regulating and monitoring, our CO2 levels and our oxygen levels. So again, if the brain needs more oxygen, it will then produce more CO2 to cause that vasodilation and thus increasing more blood flow to the brain to bring more oxygen to the brain. So it's kind of counterintuitive, you think about it like, all right, we think about it, we want more oxygen, we want less CO2, but the body actually will increase CO2 to get more oxygen it'll increase it to cause that vasodilation. So it's kind of like this feedback loop that the body has. It's a compensatory cerebral vasodilation. So if disease is present, sometimes these compensatory mechanisms are not sufficient, and that's when we lead to symptoms. So normally, if a brain needs more oxygen, it'll increase the CO2 levels, get more blood flow to the brain, and our needs are met. But now if we have cerebral vascular disease and we have blockages in these carotid arteries, even with, that extra CO2 in our blood now, and the vasodilation is not sufficient enough to meet the demands of our brain, and that's when we start exhibiting those symptoms of stroke or dysfunction. In addition to the major vessels for the circle of Willis, we have smaller collateralizations or connections on a smaller level with the vessels within our brain. So there's capillaries and precapillaries that form these collateral pathways, these anastomoses. There are two types of arterial branching supplies in the brain. We have penetrating arteries, and then these are important in terms of neural and nutrient supply. And then these diffuse circumferential or superficial arteries. So these are spread over the entire surface of the cerebral hemispheres, the brainstem, and the spinal cord through where collateral circulation can occur. And then we have the circle of Willis. When we talk about collateral pathways and patients who've had stroke, just one thing to consider is that, these collateral pathways, they take some time to develop, to form, to kind of become large enough to supply the blood flow that the brain needs. So if the process, of atherosclerosis is very slow, and it's a slow buildup of plaque over time, and the flow is getting less and less and less, the body's going like, oh crap, I better do something. Those collateral pathways are starting to get larger and larger, more pronounced, more formed, more developed. That's a good word. They're starting to become more developed. And they're the ones that kind of are, I don't want to say taking over, but like adding that extra, blood volume so the brain can function properly. So if that process is very slow, those collateral pathways become very developed, and there's less symptoms that are involved, and the patient has better, outcomes and prognosis. When whatever causes a blockage is a sudden onset or very acute, those collateral pathways are underdeveloped and not formed very well, and there's much less blood flow that can be accommodated in those collateral pathways, and those patients will have more severe symptoms and potentially more severe stroke. So intracranial collateral circulation, these are large intracranial connections. We have intracranial, extracranial connections. So that means we have connections between those vessels inside the brain to the vessels outside of the brain. And then we have small interarterial connections. So we'll go over some of those here. So the large intracranial connections, so the large connections within our brain, that's our circle of Willis when we talk about that. So that's, connecting the right and left hemispheres, connecting that posterior and anterior circulatory pathways via those communicating arteries. Intracranial to extracranial connections. These are referred to as pre-Willising. So before the circle of Willis, we have connections where we can get blood flow from those extracranial vessels outside the skull into those intracranial vessels, into the ICAs. So this refers to connections between our ECA, branches of our ECA, connecting with branches of the ICA. So basically it's branches of the ECA that connect with the ophthalmic artery and then can bring blood flow into the ICA via the ophthalmic artery and orbital arteries. So branches of the ICA will connect to branches of the ECA, so the ascending pharyngeal artery of the ECA. This chordo otoanatomic branch of the ICA connects to the maxillary artery of the ECA. So I'm not going to ask you, to memorize all these, various connections. I want you to just understand that branches of the ECA will connect to branches of the ICA and then drain into that ophthalmic artery and bring blood flow into the ICA. So kind of via that ophthalmic artery connecting to the ICA, those ophthalmic artery and the orbital artery branches connect to branches of the ECA. And we'll get blood flow into the internal carotid artery. So we can definitely get blood flow into the ICA via branches of the ECA. And that's important because if those collateral pathways are open now, so you gotta kind of take a step back and think about this now. ICA is blocked, we have stenosis. On that same side now, branches of the ECA now are feeding into the ophthalmic artery, feeding into the ICA, supplying the brain. That's going to change what our ECA looks like. So you just have to be aware of that, cognizant. You're scanning up a carotid artery, you get to that bifurcation, maybe the ICA is completely occluded. You don't even see it, and all you see is an ECA there. You Doppler it, but that looks like the ICA. Where's the ECA? You're not sure what's going on. You could be tricked, you could be duped, or you see ICA and the waveform looks exactly like the ECA. You're not sure now. And it looks like the ECA because of these collateral pathways, that connection now. The ECA vessels are now feeding into the brain. They're feeding into the ICA, acting as a collateral pathway. So it's going to change the ECA. We're going to learn in a moment that's a condition referred to as internalization of the external carotid artery, internalization of the ECA. We then have smaller interarterial communications. So this is a network of terminal cortical branches within the brain. So this is sometimes referred to as a wonderful net. It's a transdural connections across the subdural spaces of the brain between the dural arteries on the surface of the brain. So we can have smaller stenectomies, smaller strokes intracranially, and we have small collateral pathways to get around some of these smaller vessels within the brain. So just realize that there are collateral pathways that do exist, on a smaller level intracranially. So ICA has collateral branches, via circle of Willis, as well as branches of the ECA connecting with the ophthalmic artery. Vertebral artery also has, so God gave us additional collateral pathways for our posterior pathway as well, to protect the vertebral artery as well. So there are additional branches that come off the subclavian artery, further distal, that connect in anastomose with the vertebral artery if there's any blockage or any issue with that vertebral artery. So if we have blockage or stenosis within vertebral, there are additional branches that come off the subclavian. So we have a deep cervical branch, a semi-cervical branch. So again, cervical artery, think cervical spine. So those are the vertebrae in our neck. What also is coursing in that cervical spine are vertebral arteries. So again, we're just kind of playing that word association. What's the most likely, what best, so you get multiple choice, what artery serves as a potential collateral pathway for vertebral artery disease? All right, see your choice. Oh, cervical artery. I know that vertebral artery runs through the cervical spine. They got to be close to each other. So they got to be fairly close to each other to create those connections or be an anastomosis or collateral pathway. Um, in addition to those branches off the subclavian artery, the cervical arteries, we also have the occipital artery, which was a branch of the ECA that runs back towards the occiput, the back of the skull. So that occipital artery is running towards the occiput or back of the skull. Back there, we know the vertebral arteries enter through the foramen magnum, the hole in the back of our skull. It's not going to act. That's also another connection. There's another anastomosis or collateral pathway back there. So we can connect the branch of the ECA to that vertebral to again get blood flow in cases of disease. So occipital branch of ECA communicates with, again, don't worry too much, Atlantic branch of the vertebral artery. Just know we have connection between ECA via ophthalmic to that vertebral artery. This was just kind of, again, explaining what I was mentioning before about branches of the ECA communicating with branches of the ophthalmic arteries to bring blood flow into the ICA when we have occlusion to supply those pathways. And then talking about the anterior communicating in the middle cerebral artery can also be, I'm sorry, the anterior cerebral artery, middle cerebral artery also being supplied by our communicating vessels. I promise we're gonna get good at this. We're gonna get some practice of, all right, if this is blocked, where can the blood flow come from? What's gonna supply our brain? If we have blockage on left ICA, what's our pathway? What are some of our channels? What are we gonna expect to see in the body? Blockage here, we expect to see increased blood flow there, increased blood flow in our vertebrals. We know we can get blood flow up the posterior communicating and then into our ICA to feed our pathways on that side. If this is blocked, we know we can get increased flow here, up, and then over and down. So again, feed middle cerebral, and then in addition to going down, it's going to go up and feed the pathways up there. So we're gonna get good at this. We also have some additional branches that can feed into the vertebral arteries as well. So in addition to the cervical arteries, we have these costocervical arteries that will branch down and bring blood flow to our ribs, as well as the thyrocervical arteries. I'm just gonna, just a quick thing, just talking about some of the difference between like TIA, rind, like CBA stroke. So the importance of the carotid arteries. So the majority of strokes, or many strokes, are involved disease in the carotid artery territories. So blood that passes the two ICAs nourishes 75% of the brain's tissue. So again, 3/4 of our brain tissue is supplied by our two internal carotid arteries. So again, it's vital. The origins of the CCAs are more receptive to emboli. So if we do see a clot in the internal carotid arteries, it's more likely to be down near the origins of the ICAs. Atherosclerosis is going to be most prevalent at that bulb and bifurcation. So where we get the bulb into that bifurcation, that area is going to be our spot where atherosclerotic plaque develops. So emboli is going to be an acute thing. This is someone that has a clot in their heart that gets ejected from the heart. So most common source of emboli is going to be cardiac in nature. It's going to be ejected from the left ventricle, enter into your aortic arch, and then from there it can go up, up the left common carotid, and go into the innominate, and then up the right common carotid artery, and then usually gets lodged somewhere in there. Then ultrasound provides a fast, portable, non-invasive, repeatable, inexpensive way to image these vessels. So this is just kind of summarize signs and symptoms. So the signs and symptoms that a patient exhibits, we can kind of, I don't want to say assume, but we can kind of narrow down and pinpoint where that disease potentially could be based off the signs and symptoms that patient is presenting with. Some symptoms are transient, meaning that they come and go. Some symptoms are permanent. The symptoms that they exhibit, we can kind of localize, is it an anterior circulatory symptom? Or is it a posterior circulatory symptom? Or is that symptom non-localized? So we can't really tell which pathway is affected. So when we're talking anterior circulatory symptoms, we're thinking ICA disease. Posterior circulatory symptoms, we're thinking vertebrobasilar disease. So kind of use that or make that association. Posterior circulatory is vertebrobasilar. Anterior circulatory pathway is ICA. Or carotid. All right, so TIA, we talked about TIA or a mini stroke. So TIA stands for transient ischemic attack. So this is a focal neurologic deficit with full recovery in less than 24 hours. So a patient, all of a sudden, they exhibit some stroke symptoms and they only last, for maybe 12 hours, 10 hours, couple minutes, couple seconds. It's a short lasting neurologic deficit, but it has to be less than 24 hours. So they fully recover, they fully resolve, or those symptoms fully go away in less than 24 hours. So it can be sensory, motor dysfunction, speech impairment, something a little more non-specific, headache, dizziness, tingling, numbness in the extremities. Could be a vision disturbance, so blurred vision, confusion, altered mental status, paralysis of an extremity or an arm, depending on the pathway. And these are usually due to some sort of embolic event. These mini strokes can also be a warning sign of an impending stroke or an impending larger stroke. So we have to take these very seriously, if you ever have a family member or a patient that you're working on and they have a sudden onset of a stroke symptom, and it can last for a couple minutes, and they tell you, no, I'm fine, I'm good, even though they're telling you that they're good, they still should go to the hospital, get checked out, because then that could just be an impending sign of either a heart attack or a more severe stroke that could be coming. With these TIAs, if we administer a medication called TPA, so that's a hemolytic medication. You might refer to it as like a clot busting medication. If that can be administered, within the first 3 hours of, or it has to be administered within the first 3 hours of the onset of the symptoms, that will dissolve and break up that small little emboli. So moving from TIA in terms of severity, we enter into what's called a RINE. So, oh my God, man. The RINE refers to reversible ischemic neurologic deficit. So these are patients, they have their stroke symptoms, but they last longer than 24 hours, but less than 3 weeks. So they might be in the hospital for several days, and they have weakness, they have motor dysfunction, speech impairment, whatever their symptom is, they have it, but they still fully recover, so they regain their full, function as they were prior to having that episode, but it lasts longer than 24 hours, but resolves within 3 weeks. They make a full recovery within 3 weeks. So that's our RINE, reversible ischemic neurologic deficit. And then any patient who has permanent symptoms, they're said to have had a cerebrovascular accident. So this is our CVA, our true stroke. So that brain territory, has been ischemic for 24 hours and shows evidence of profound brain damage or tissue death. These neurologic deficits are permanent. And then with stroke, you have to also keep in mind there are actually 2 kinds of stroke now. So there's ischemic stroke. So the term ischemia, we think of reduced perfusion of blood flow. So something that's limited the amount of blood flow getting to the brain, the tissue is starving for blood, starts to become damaged because there's reduced blood supply. And then we also have hemorrhagic stroke. So this is a hemorrhage, think brain aneurysm now, or brain bleed. You just have to be careful when we're talking about stroke. Is it an ischemic stroke, or is it a hemorrhagic stroke? Is it a brain bleed? So I know growing up, I always think of a stroke as, blood vessel popping in your brain. That's your stroke. You're having a brain bleed, you're hemorrhaging. I never, as a child, never really thought of the stroke being an ischemic stroke where it's starving for blood. So with the CVA, if the patient has a CVA, they're going to get a CAT scan or an MRA of the brain, to figure out, is this, ischemic versus hemorrhagic? Because that's important. Ischemic stroke, we want to administer, hemolytic medication, break up the clot, break up the blockage, increase flow, prevent clot, so you might anticoagulate, we don't want to do that with a hemorrhagic stroke. It's the complete opposite. That stuff will cause them to bleed more, and we're just making the situation worse. Thankfully, the majority of strokes are ischemic in nature. So it's more likely an ischemic stroke than a hemorrhagic stroke. So ischemic stroke, brain infarct or tissue death occurs due to insufficient blood supply. Common causes are atherosclerosis, buildup of those atherosclerotic plaques. Where do we see it? Most of the time in the bulb and bifurcation of the ICA, the bulb of the CCA bifurcation into the ICA. Could also be due to thrombosis of the vessel or embolism. So we can have emboli, lodging or blocking the vessels. We can have ischemic stroke due to thrombotic, a thrombus occluding the vessel. Embolic stroke, so little pieces of either atherosclerotic plaque or emboli or blood clot breaking off. These Lasunar strokes, these are very tiny ischemic strokes. They're occlusive lesions in small perforating vessels. Or the stroke could be of unknown cause, this cryptogenic stroke. So we can't quite figure out the cause of that ischemic stroke. All right, so hemorrhagic stroke. So this thing again, rupture or brain aneurysm. So rupture of an artery or vein that allows blood flow to flow into and around the brain, compressing the brain. So causes of hemorrhagic stroke could be hypertension, high blood pressure. Atherosclerosis, we know, weakens the integrity of the vessels, leads to that vessel becoming weak, becoming aneurysmal potentially, and leading to rupture. There could be rupture or of an aneurysmal segment of that brain. Hemorrhagic stroke leads to parenchymal hemorrhage. So this could result from, again, high blood pressure, atherosclerosis weakening the vessel. Hemorrhagic strokes could also be, we can also have subarachnoid hemorrhage. So this usually results in brain aneurysm. So the rupture of that aneurysm fills that subarachnoid space, that puts the pressure on the brain. We could also have hypotension stroke. So patient has very low blood volume, very low blood pressure. This reduces oxygen supply to the brain. So anterior circulatory territory symptoms. So our anterior circulatory pathways include, the ICA, the internal carotid arteries, then all the things that are fed by the internal carotid arteries. So our anterior cerebral artery, middle cerebral artery, anterior communicating, and then, the cerebral pathways or the cerebral vein hemispheres that are fed by those vessels. So the anterior circulatory symptoms, we refer to them as lateralizing, referring to either right or left. So we can figure out where the disease is based off of the patient's symptoms because the symptoms will lateralize. It'll affect one side of the body or the other. So all these symptoms here, hemiparesis, hemiplegia, hemiparesthesia. So the symptom is that paresis, plasia. The hemi is just referring to one hemisphere or one side of the body. So we refer to these symptoms as being unilateral because they only affect one side of the body. So paresis is a slight paralysis or weakness. So this is when we think about a patient who's got right-sided weakness. They're we put their arms out in front of you and that one arm starts to drop. Or, they ask you to squeeze, the neurologist will be like, squeeze both my hands. One hand is very weak, where the other one has good grip. So paresis is a weakness, slight paralysis or weakness of one side of the body. Pelagia is complete paralysis of that one side, so they can't move their arm or their leg at all. So plasia, hemiplasia, refers to one side of the body. So that ending plasia refers to paralysis. Hemiplasia is paralysis of one side of the body. Paresthesia, we saw that with our vascular, with peripheral vascular disease, PAD. So that's that numbness, tingling, prickling, or burning sensation. So the pins and needles. Again, affecting only one side of the body, hemiparesthesia. So with all these symptoms, we have to understand that the symptom, the side of the body that the symptom is on, when it's below the neck, is the opposite ICA. So there's a crossover that happens kind of like right around here, where left side of the body is affected by the right side of the brain. So like that side of the brain controls this side of the body. This side of the brain controls the opposite side of the body. So there's that crossover. So when you start thinking about symptoms, symptoms of the eye are the same side, but when we're talking about the body, it's the opposite side. So when you start getting questions about, patient presents with left-sided, paresis, left-sided weakness, or left arm paralysis, you know right away that it's the right side of the brain that's affected, and it's the right ICA. So it's the right anterior circulatory pathway. So these are all anterior symptoms: paralysis, plasia, paresthesia. So weakness, paralysis of one side of the body. So what happens if I have a patient who has right arm weakness, left leg weakness? It's not, we can't assume that it's both sides. So if the symptoms are both sides of the body now, so it could be one arm and one leg, two arms, both arms are weak. That now falls into, we're gonna see in a moment, that falls into posterior circulatory issues. So now we have to assume cerebrovascular. So when these symptoms are now bilateral, both sides of the body, we're thinking now more it's cerebrovascular disease than anterior circulatory. So anterior circulatory has to only be one side of the body. So we can't have a right arm and a left arm. We can't have a right arm and a left leg. So it has to be only relegated to one side of the body only. And then just know that it's the opposite ICA that's affected, or the opposite side of the brain. So left side of the body, right side of the brain issue, right ICA. Left side of the body, no, that's what I said. Right side of the body, left side of the brain is what's affected or controlling that. So it's right, left ICA, left anterior circulatory pathways. We have some additional ones. We also have speech. So aphasia, dysphagia. So aphasia is a complete loss of functional speech, whereas dysphagia is kind of like the slurred speech. So someone who's presenting with dysphagia, they might sound like they're intoxicated or drunk or slurring their speech, but they still kind of make sense. Aphasia, they might not be speaking at all. So you'll ask them questions, they're just kind of staring at you. They can't form the words, or what they're saying makes absolutely no sense. They're just like, they're saying just random words that don't make any sense, Was it Bruce Willis? Go back for him. He suffers from aphasia. So he fortunately his career. Anyone see that? Like, didn't know that Bruce Willis, the actor? No. That's why he stopped acting and making films. He's suffering from aphasia. So with this, we can actually locate or localize which ICA is affected based off the patient's handedness. So aphasia, dysphagia. So determined by patient handedness. Not even word handedness. Right-handed. Just kind of break it down. Left-handed. Left-handed, excuse me. The easiest way to memorize it. So if a patient's right-handed and they're presenting with, expressive aphasia or dysphagia, if they're right-handed, we know it's the same side as the right ICA that's affected. Because again, the speech centers are the same side, so the motor function was controlled by the opposite side, but our speech centers are the same side of the brain now that's affected. So it's a little bit easier on that side. So again, we don't always want to go with this because again, back in the day, left-handed people were forced to become right-handed. So, some of you was in here, right? Or
What?
you're left-handed and
Yeah.
forced to be right-handed.
Oh, no, I'm just left.
You're just left-handed, okay. So we stopped that, but again, so you can't always go by right-handedness. The other caveat to that, they can't talk to you. Are you right-handed or left-handed? All right. Can you imagine her? But boards again likes to throw that in there because it can be determined based off handedness. So that's just kind of like your easier breakdown. It goes into all the explanation about like how the speech is controlled by this portion of the brain. Just kind of boiling it down. If you're right-handed, it's the right ICA. If you're left-handed, left ICA. But the nice thing about boards and all these other questions, they'll throw that in there. And they'll also throw a body symptom in there, like a unilateral body symptom. Like, all right, good, all right. The left side of the body's affected. I know it's the right ICA. Well, a right-handed patient presents with left-sided, paresis in their leg, and where's the potential location of the disease? And automatically it's going to be right ICA or right anterior circulatory pathway. The other big one I want you guys to just familiarize yourself with is amaurosis fugax. They love amaurosis fugax. So this is a transient temporary blindness. So they refer to this as, you might see it pulling the wool over your eyes or pulling the shade over your eyes. And it's temporary or partial, it's temporary, so it's transient, meaning it's going to go away. Partial or total blindness of one eye. So thankfully, again, this is, since we're above the neck now, it's the same side that's affected. So if I have partial or temporary blindness in that one eye, I know it's the same side ICA that's going to be affected. So if it's left eye, it's left ICA. Right eye, it's going to be right ICA. So that's what that's saying. So it's due to, occlusion of that ophthalmic artery. And it's ipsilateral, it's the same side where the disease is. All right. So posterior circulatory pathways now. So these symptoms are non-localizing, meaning that they don't affect, they're not affecting just the right or the left. So these symptoms referred to as non-lateralizing. But they're very specific symptoms now to the posterior circulatory pathways. So we can have vision disturbance affecting one eye with the anterior. But when the vision disturbances now affect both eyes, we're thinking posterior circulatory pathways. So any bilateral symptoms now, any bilateral vision disturbances or blurring, patients who have diplopia, which is double vision. And since that posterior pathway affects our posterior circuit, affects the cerebellum, our balance coordination, things like, drop attack. Or drop attack is defined as falling to the ground without loss of consciousness. So it's different from syncope. Syncope is fainting, but drop attack is that loss of consciousness. I'm sorry, falling to the ground without loss of consciousness. So the patient's still alert, they're oriented, they just drop like a ton of bricks, fall to the ground. This is a tricky one that I don't want you to confuse with dysphasia. But dysphasia with the S is speech. So that's a good way to kind of memorize that. When there's the S in it. Dysphagia. Dysphagia with the G is difficulty swallowing. So S is for speech, dysphagia or aphasia. With the S is speech. Dysphagia with the G is difficulty swallowing. Ataxia is muscular incoordination. So someone who has ataxia, if you held them, you ask them, all right, touch your finger to your nose, they're going like all over their face. They can't control their muscle coordinations. They can't do something like that. Reach out and grab this pen. They're like, that would also cause them to have an abnormal gait. So if they're walking, they're walking all funny. They have an abnormal gait because they can't control their muscle coordination. Now bilateral signs. So we saw paresis and paresthesia. So weakness now that's affecting both sides of the body. So a right arm and a left leg. We have both sides of the body now involved. We're not thinking posterior circulatory pathways. Again, look at what the question's telling you. Both sides of the body involved. You now have to think posterior circulatory pathway. Vertigo is another big one too. That's sensation that things are moving and the room is spinning around you. So it's not necessarily dizziness or lightheadedness. You actually get the sensation that things are spinning around you. It's like, holy God. I don't know if anyone's actually experienced vertigo. Thankfully, I never have, but I can only imagine. So it's difficulty maintaining that sense of equilibrium. So sensations of either moving around in space or having difficulty, having objects move around a person. These are all posterior. So bilateral vision disturbances, again, both eyes involved, double vision, drop attack. So they're conscious, they just fall to the ground. Dysphagia with the G, difficulty swallowing. Ataxia, in coordination of their muscles. Bilateral body symptoms, so paresthesia, paralysis, if it's both sides of the body, and vertigo. So vertigo again is that big one that they like. They love vertigo, they like ataxia, knowing that it's bilateral symptoms, bilateral vision disturbances, bilateral body symptoms. And the very last ones are ones that are non-localizing. So these are symptoms that, we're not sure. Is it anterior or posterior? We can't tell based off of some of these stroke symptoms. Or something as benign as a headache, you know, confusion, memory loss. We have elderly populations coming in. You might expect confusion, memory loss, so family members know them best. They're bringing them in for a reason, be like, and just don't assume they're, have dementia. They're just, altered mental status. They're not acting right. Syncope. So when they actually faint on you and black out, we don't know. This is a transient loss of consciousness. So again, just be careful when you're asking, the patient, they might say, "Oh, I fainted. Do you remember going down?" Yeah, I remember it. All right, then that wasn't syncope. Dizziness, dysarthria. So this is affecting the muscles of the tongue. So this referred to as a tight tongue. Auditory disturbances. So they're hearing sounds and noises. And those are all some examples of some non-localizing symptoms. So the little caveat to this is patient could present and board's questions can give you a non-localizing symptom. So they can say, patient presents with sympathy. Yeah, I have sympathy. Syncope and vertigo. You would still answer posterior because that syncope is non-localized. Could be anterior, could be posterior, we're not sure. But the only other symptom that they have is vertigo. So then I would say, it's most likely posterior circulatory, it's most likely vertebrobasilar based off that patient's symptoms. So they had some vertigo and then they blacked out. They had the syncopal episode. If they just give you non-localizing ones, you can't make that determination. And that's it. That's all I wanted to do today. We'll start just memorizing your stroke symptoms, which ones are anterior, which ones are posterior, what are some of your non-localizing ones, because that's going to help you infinitely on breaking down a lot of these board cerebrovascular questions. That's the main thing about cerebrovascular boards is being able to look at your waveforms, look at the symptoms, understand, break apart the question, where's the disease? And we're going to start in subsequent lectures looking at the waveforms and being able to pinpoint, is the disease higher up or is the disease proximal to where I'm imaging? Is the disease down here or is the disease up there based off our waveforms? Is it right ICA? Is it left ICA? Right vertebral, left vertebral? Is it proximal and distal? You're going to figure that all out.